we used to call this juvenile rheumatoid arthritis, but it's now juvenile idiopathic arthritis. And so we're going to try to define this condition and discuss the diagnostic criteria, look at the different subtypes, and then try to discuss at least one nonsteroidal anti-inflammatory, a biologic, and a disease-modifying anti-rheumatic drug used in the treatment. So this is basically a medical talk, all right? And we won't really do all of this stuff. But, in 1997, they basically decided to try to change the name with new classification criteria, because we used to call this JRA, juvenile rheumatoid arthritis, and you'll still hear that, but really a more encompassing term is juvenile idiopathic arthritis, because that really covers a lot more of the types of arthritis that children can have, or juvenile inflammatory arthritis. And it's a chronic arthritis in childhood. It's one of the more frequent chronic illnesses, and these can be an important cause of short and long-term disability. And if you've ever seen a child who's had true chronic pediatric arthritis, I mean, this is a debilitating, all-encompassing disease that takes over their life. So this is not a single condition. It's a group of related, heterogeneous, phenotypically diverse immunoinflammatory disorders. You can spend your whole life studying these conditions and make a very small amount of significant progress. And we believe they're activated by contact with external antigen or antigens. So you have presumably a genetic predisposition to this, and then something activates it. So that's why we put things like Lyme arthritis kind of in this category, because the Lyme spirochete does not actually cause the disease. It activates your body to attack itself. So the incidence differs by geography, obviously, because geography carries differences in genetics where populations are homogeneous. So incidence in Japan is 1 in 100,000, whereas in Norway it's 20 in 100,000. The prevalence also different: 10 in 100,000 in France, 400 in 100,000 in Australia. Sort of an overall, 100 per 100,000 people. So, so about 1 in 100, which is not that uncommon. 1 in 1,000, so not that uncommon. There's about 300,000 children in the U.S. that have chronic arthritis. So the classification criteria for JRA, which was the American College of Rheumatology classification from the 1970s. So there were 3 types of, and basically determined them by onset. So oligo, which was pauciarticular, so poly, and then systemic. And so that was based on the first 6 months of your disease, kind of how many joints were involved. And then the Europeans called it juvenile chronic arthritis, and then they tried to bring these together in the early 90s to call it juvenile idiopathic arthritis. And this is what's more commonly used as a term now. So this is one of those conditions that affects girls more frequently than boys for almost all of the subtypes except for systemic JRA. So oligo 3 to 1, JIA with uveitis 6 to 1, polyarticular 3 to 1, and the systemic is even. And the systemic one is the one in which the kids look. These are the ones in which you really can't differentiate whether they have a septic joint or not. They look sick. They're febrile. Now, you might be surprised to find that these have mortality associated with them, right? You don't think of arthritis as having mortality associated with them, but they do. And very low numbers, but still it's surprising to orthopedists when they find out that there's mortality associated with juvenile arthritis. They have a 4 to 14-fold increase in mortality compared with the general population. The causes are cardiac, infectious, and this condition called the macrophage activation syndrome, which is a real emergency. So their functional abilities are something that we are concerned with, because that's our main concern is how people are functioning, and they all have diminished function, and that's the area that we might be able to help with, because we're basically all about getting you back to normal function. There's a lot of things that we can do to try to help with that. All the way from steroid injection to arthroscopic synovectomy to joint replacement. So the classification criteria for juvenile idiopathic arthritis: you have to be less than 16 years old. You have to have your symptoms for at least 6 weeks. You have to have arthritis in one or more joints, and that's defined as swelling or effusion or presence of 2 or more of the following signs: decreased range of motion, tenderness or pain on motion, and an increased temperature. And you have to exclude other conditions, obviously, like septic arthritis. And these are just pictures of kids that are in the hospital with arthritis. And this is what they think of the nurses. Ha, I'm going to stick you. Ha. So there's no lab tested diagnosis JIA. So we do send all these labs, right? We send CBC, we send rheumatoid factor, we send ANA with a titer, we send SED rates, C-reactive proteins. I don't really send anti-CCPs, but it's one of the newer tests, and maybe we should, but I'm not really sure. I'm not really sure of the significance. I let the rheumatologist send some of the more esoteric stuff if they want to get those. But really, these are clinical diagnoses, and if I'm suspicious, then I'll send these labs, because a lot of these conditions are seronegative, especially in children. So maybe half of the juvenile arthritises are seronegative, which is really kind of annoying, and hopefully in the future there'll be less of those. So on X-rays, what you may see is soft tissue swelling. You may see osteoporosis. You can see a difference between those two knees, right? So the knee on the left has decreased bone mineral density. It actually has an increase in size over the knee on the right. It has a narrow joint space. And so those are all things that come as a result of chronic arthritis. So the increased blood flow actually causes increased growth in that limb. You have overgrowth of the epiphysis. You have overgrowth in limb length. You may have subchondral bone erosion. You have cartilage destruction. And so you'll have a narrow joint space. You may eventually get joint subluxation. If things get bad, you can have ankylosis. You get osteopenia from disuse, osteoporosis. And those are in more significant cases, but you amazingly can see it in very, very mild cases as well. It doesn't take long for a joint to become osteopenic from disuse. It really takes just a matter of weeks before you start to see disuse osteopenia. So what are the causes? They're immune-mediated diseases, so they have abnormal immunoregulation, they have abnormal cytokine production, and the inflammatory pathways are much more complicated than they were when I was in med school, and probably already much more complicated than when you guys were in med school. They get more and more complicated all the time. They have HLA associations that are rather complicated. There's environmental triggers that can be anything from an infection, trauma, stress. If you ask someone with chronic arthritis what hurts, they'll, they may draw everything. There are certain patterns that they have. Large joints tend to go together, small joints tend to go together. And you can see this particular patient, what they're on. They're on methotrexate, prednisone, folic acid, piroxicam, Prevacid, Humira, ranitidine. So this is a chronic disease, big time. So this is the typical pathway for and where the targets are. So this is for rheumatoid arthritis immunopathology, right? So you target the activated T cell, which then differentiates into either an activated macrophage or an activated B cell, and the activated macrophage releases IL-6 or TNF-alpha or IL-1, and then the activated B cell either releases autoantibodies like rheumatoid factor or IL-6, and then this is where all these medications can work. So anti-TNF-alpha is etanercept or infliximab or adalimumab, or anti-IL-1 is anakinra, or anti-IL-6 is tocilizumab, or anti-CD20 is rituximab. So this is all stuff that obviously we don't prescribe, but hopefully it eventually will eliminate some of the things that we have to do. The problem is that the inflammatory pathway is necessary for all infection control as well. So when you shut down this pathway, you also make the patients susceptible to infection, and that's why we see these patients as well, because they develop infection, they develop abscesses, and they can be pretty significant infections. And so we may not see them for their joint problems, but we may see them for subperiosteal abscess, or osteomyelitis or septic arthritis. So obviously I don't have to explain the parts of a normal joint to you, but so the inflamed synovium will create this pannus, which then starts to essentially destroy the cartilage. They'll secrete things that destroy cartilage, like matrix metalloproteinases, and the pannus will basically creep along the joint and destroy the joint from direct contact, and also from secreting all of the factors that destroy cartilage as well. And then once you've destroyed the cartilage, you basically get in and start destroying the subchondral bone as well. And so the classification criteria, so 1, systemic; 2, oligoarthritis, persistent or extended; 3, polyarthritis, rheumatoid factor negative; 4, polyarthritis, rheumatoid factor positive; 5, psoriatic arthritis; 6, enthesitis related arthritis; and then 7, undifferentiated, basically fits no other category or fits more than one category. So the systemic onset is about somewhere between 5 and 15%. The polyarticular is about 20%. And of these, 85% are rheumatoid factor negative. Okay, so these are, so these are the ones that, like, the lab tests are essentially negative on. So it's a big subset. Oligoarthritis, 50 to 80%. The juvenile psoriatic arthritis, which are pretty easy to identify because they have some of the skin changes, about 7%. And then the enthesitis related arthritis, the more axial ones, and then the undifferentiated. So systemic JRA, by definition, arthritis with or preceded by a daily fever of at least 2 weeks duration. So the fevers are quotidian, for at least 3 days, and so they may have they are accompanied by one or more of the following. So an evanescent rash. So that's why I ask all these patients, do you have a rash, or have you seen a rash? Lymph node enlargement, and then organomegaly, either liver or spleen, and then a serositis. And so this is their typical fever pattern. So they're having a spike that occurs every day. And then they're also having a rash that usually accompanies. And so the rash is sort of salmon, pink-colored, maculopapular, usually the trunk and extremities, migratory, and it's itchy in about 5%, and it basically sticks around during the fever spike. So, and you'll hear this story eventually. So there's an evanescent rash there as well. So about 10 to 15% of all JRA patients, and usually they're younger, and like we said before, male to female ratio of 1:1, variable number of joints, and about 100% of them have fever, 95% have a rash, 85% have either hepatic or splenomegaly, 70% have lymphadenopathy. And then some of them actually have pericarditis or pleuritis, right? So they may have a cough, they may have a wheeze. So, and there's a picture of your hepatosplenomegaly patient. So now the macrophage activation syndrome, which you may have not heard of before, is a devastating complication of systemic JIA. And so basically the way you can diagnose it is macrophages are ingesting other hematopoietic cells in the marrow on bone marrow biopsy, and it's associated with cytomegalovirus, Epstein-Barr virus. It has a 10 to 20% mortality rate. So this is an emergency. Acute onset of fever with bruising, purpura, mucosal bleeding, elevated liver enzymes, and other things that are made by the liver, coag factors, fibrin, D-dimer, precipitous drop in your white count, your platelets, fall in sed rate, fall in your fibrinogen and clotting factors, so you're going into DIC. And so basically you're getting liver failure, and this is, ICU territory, IV steroids. So polyarticular JIA, rheumatoid factor negative, 5 or more joints in the first 6 months of the disease. The joint involvement is asymmetric, so large joints of knees, wrists, elbows, and ankles most affected. Usually they have morning stiffness, so this is one of the questions that I ask. Do they wake up feeling really stiff? So if they're answering yes to that question, yeah, they're really stiff. They take a while to get going in the morning. They wake out of bed and they're really stiff. Then you might be dealing with this. It's very similar to adult RA. Usually it's girls, starts in adolescence. They may have rheumatoid nodules, which are don't really have any, they don't really have any sort of rheumatoid factor or anything in them. They're not in joints. They're near joints, but they basically have a bunch of giant cells in them, and they have early onset of erosive synovitis. These are for the RF positive group. So they tend to have more symmetric joint involvement, and they have the small joints of hands or feet, and so these are the ones that look like, when you think about older people with severe hand RA and their hands are really starting to kind of change shape and be affected by their RA. That's this subgroup. So they really transition into adult RA, and they have essentially the features of adult RA: cervical spine involvement. Their temporomandibular joint may become involved. They may have difficulty with chewing and stuff like that. So this is the result of severe TMJ involvement. So their jaw is receding as a result of TMJ destruction. They may have difficulty opening their mouth even, and sometimes they end up with TMJ joint replacements just so they can eat. And that is a thing that's been done for over 20 years now. I don't know how good it is, but in the absence of other options, it's better than having to eat through a straw. So this is the typical hand appearance, and certainly that looks a lot like how an adult hand starts to look. You can see the swan neck deformities at the digits as they start to develop the adult features of rheumatoid arthritis in the hands. They may eventually end up with tendon ruptures as well. So rheumatoid nodules, about 5 to 10% of children with JIA. They are most commonly on the elbow. They tend to be on pressure points. They can be on the bridges of the nose in children that wear glasses. They're usually mobile. They're non-tender. And sometimes we excise them surgically if they're big enough. They can last for months to years. So, oligoarticular JIA, arthritis in 1 to 4 joints in the first 6 months of the disease. Girls 1 to 4 years of age. Knees, ankles, and elbows, usually painless. These girls may have uveitis, which is sort of subacute, and if not diagnosed, can be a problem. Up to 20% can have uveitis, so they have to be sent. And luckily, once we send them to rheumatology, they'll send them on to ophthalmology, but it has to be, they have to send them quickly because it's very treatable if you catch it early. So Persistent oligoarthritis, no more than 4 joints throughout the disease course. Extended, a total of more than 4 joints after the first 6 months. And more typical of the RF-positive polyarticular disease. So uveitis, I just bring this up because it's an intraocular inflammation, and it can be asymptomatic, and the slit lamp exam will detect the anterior chamber inflammation. Tends to be the girls who are ANA positive, and those who have an onset before age 7, they're at much higher risk. So the prognosis, very good in 25% of cases. Another 25% may require surgery for cataracts, and then half may require prolonged treatment for moderate to severe chronic inflammation. But overall, the prognosis is good, so, especially if you get to it early. So, highest risk is usually within the first 2 years of onset, and most would develop eye disease within 5 to 7 years. More than half have bilateral involvement. Treatments: topical steroids, sub-Q methotrexate, Remicade, sub-Q Humira, and Enbrel. And I won't belabor you with the slit lamp guidelines there. Psoriatic arthritis, so it's arthritis and psoriasis, or arthritis in 2 of the following. So dactylitis, which is a sausage-like swelling of either toe or finger, nail pitting, or psoriasis in a first-degree relative, slightly more female, and symmetrical involvement involving the large and small joints. So we also used to call this arthritis mutilans because of the deformity that happens in the hands. So you usually have sort of the pencil and cup deformity that happens in the fingers, and the fingers start to become sort of shortened, and as the destruction proceeds, the phalanges kind of like basically collapse onto each other, and the fingers become shorter. So now the spondyloarthropathies, what we used to call in JRA, in JIA are called the Enthesitis-related arthritises, right? So these are the HLA-B27 conditions. These are the axial arthritises, right? So typically they'll have SI joint tenderness or lumbosacral pain. Their HLA-B27 is positive. This is why I'll send an HLA-B27 on some of these patients. Usually it's onset of arthritis in a male after age 6. Ankylosing spondylitis is one of these conditions. Sacroiliitis with inflammatory bowel disease, Reiter's syndrome, can't see, can't pee, can't dance, right? Acute anterior uveitis in a first-degree relative. So usually boys 8 years and older. Large joints of the lower extremities. They may have heel pain, Achilles tendonitis. 90% have sacroiliitis. 20% have iritis. They have low-grade fevers, decreased appetite. So these guys are kind of like, they usually sort of just look, they don't look great, and you can't really tell why. And they're usually complaining of either back pain or sort of like pelvic pain. So now, what are the medications that we use? So first-line medication, nonsteroidal anti-inflammatory agents. We obviously use a lot of ibuprofen. The rheumatologists use a lot of naproxen. The disease-modifying anti-rheumatic drugs, methotrexate, Plaquenil, sulfasalazine, then the biologic response modifiers, and then the steroids, and then miscellaneous others, and we'll talk about those. So, NSAIDs approved for pediatric use: aspirin, Tomectin, naproxen, ibuprofen, indomethacin, Mobic, and Celebrex. So, naproxen dosing 10 to 20 milligrams per kilogram per day with a max of 1,000. Ibuprofen 30 to 40 milligrams per kilogram per day with a max of 2,400. And then Indocin 1.5 to 3 milligrams per day with a max of 200. The rest I really won't discuss because we don't use them. Methotrexate, it's usable. Usually it takes 6 to 8 weeks for improvement, the kids can't drink, and this is only an issue for teenagers. This is obviously a busy, complicated slide, which kind of shows again where all of these medications could potentially be used to target. And the more we understand about this, the more potential targets there are. So now the biologic agents which target cytokines involved in inflammation: TNF, IL-1, IL-6. So Enbrel, which is approved for JRA. So that's a twice a week sub-Q injection, and they get improvement by the third or fourth dose. But you have to watch out for either chickenpox or suspected viral infection, and you can have a local site reaction. So, I mean, this was revolutionary when they started using it, right? Like, so by the third or fourth injection, you're getting better. That's amazing. Remicade is an infusion. You can have a risk of anaphylaxis, but without that, 3 milligrams per kilo IV, and then you can increase the dose. You can have improvement after the very first dose. Not approved for children, but I think it is, off-label being used in some of the older kids. So anakinra blocks IL-1, used in systemic JRA, but not approved. It's a very painful daily sub-Q injection, so you have to rotate your sites. And for some kids, that's a deal breaker. They just can't handle it. So Actemra, everything is ends in the same letters now. Active systemic juvenile idiopathic arthritis, 2 years of age and older, who are not responding to other treatments. So every 2 weeks IV over 1 hour. So they come in for an infusion, and that's not bad. Come in once every 2 weeks for an infusion, and your symptoms improve. So Humira, the TNF blocker, over age 4. So there's a pen, get a painful injection, but you can add lidocaine, and you can also do it weekly if you want. And Orencia is a beta set, is a IV infusion every 30 minutes, and you can also in adults do a sub-Q self-injection if you want. So the steroids, IV Solumedrol or daily prednisone. Now the problem with these obviously is the side effects of the steroids, right? Because people do not like the side effects, the weight gain, the hirsutism, the sort of asymmetric weight distribution. Like they get the buffalo hump or the moon face or things like that. So people do not like to be on systemic steroids if they can avoid it. And so it's really only used temporarily now until these other medications are effective. So it may only be used for a couple of weeks. It's very rare to have someone on steroids for long term anymore. Now, joint injections, though, are being used because if you have a joint that's persistently symptomatic, and you can shut that down with an intra-articular injection, and then they don't need to be on medication, then why not do that, right? And that's why they'll sometimes be sent to us, right? So they have a knee that's really bothering them, but everything else is being handled with naproxen. Then why not just put 40 or 80 milligrams of aristaspan in a joint, and then shut the whole process down, and that really makes sense. So miscellaneous treatments that are sort of not being used that often. Thalidomide is actually used. Bone marrow transplants, very experimental. Stem cell transplants sometimes, to sort of reset the immune system completely in some of these kids so that they no longer have the condition. Physical therapy, obviously used for people who have affected joints who become deconditioned. So, all right. Questions? So now you know as much as most orthopedists know about JIA.